Okay, everyone. Thank you so much for joining us for the FDA Alumni Association's second virtual speaker series event. We're thrilled to have Dr. Stephen Ostroff with us today, and we will turn to him in a moment. But I would just like to take this opportunity to thank everyone for joining. I speak on behalf of Angela and myself and the entire activities committee when I say we have struggled for a long time for a mechanism to connect with people across the country. And it was only a global pandemic that actually prompted us to start to do these more virtual events. But we're so happy to be able to do them, both to reconnect and to learn something in the process. So just in terms of logistics, I will be turning this over in a moment, but during the webinar, there will be a discussion, and then through the chat function, if you have any questions for Dr. Ostroff, we will be collecting those during the presentation and then leave a little time at the end for questions. So with that, I will take a moment just to introduce our Master of Ceremonies today, Howard Sklamberg, who is a dear friend and colleague of mine. Howard has many talents, but today I'll just focus on his time at FDA, where he served in various roles between the years of 2010 and 2017, including as the Director of the Office of Enforcement, the Deputy Associate Commissioner for Regulatory Affairs, the Director of the Office of Compliance in the Center for Drug Evaluation and Research, and as Deputy Commissioner for Global Regulatory Operations and Policy. Howard is currently a partner in private practice in Arnold & Porter, and we are thrilled to have him to help to manage this discussion today. So with that, I turn it over to you, Howard. Thank you.
Thank you very much, Lisa, and it's a pleasure to virtually see everybody. I decided to go with a scientific and hopeful background of the man on the moon. But I look forward to having a good discussion with Steve today about lots of things related to COVID-19. So first, a little bit of biography of Dr. Ostroff, who was my boss for periods of time and a colleague for periods of time, and always a great person to work with in whatever capacity. Steve has an incredibly distinguished and varied background, and he's one of the folks who talks about COVID-19, who actually really should be talking about COVID-19 because of all this experience. So Steve is a graduate of the University of Pennsylvania Medical School. I won't say the year, but he then was a resident in internal medicine at the University of Colorado and also preventive medicine at CDC. He had a long career, rich career in government, in the public health service, where he reached the rank of Rear Admiral and served as Assistant Surgeon General. He was in the Center for Disease Control and Prevention, where he was Deputy Director of the National Center for Infectious Diseases at CDC, where he worked on all kinds of outbreaks. He worked for the, I was going to say state of Pennsylvania, but Commonwealth of Pennsylvania, where he was the director of the Bureau of Epidemiology and the acting physician general for the Commonwealth. He then came over to FDA, where he had a whole bunch of roles. Initially, he was the chief medical officer for the food program. He then became FDA chief scientist, and he had 2 stints as acting commissioner of FDA, where he dealt with all sorts of issues, and obviously worked on outbreaks personally, both at CDC and at FDA. And Steve is also a big baseball fan and can always inject humor into the most serious issues. So I look forward to our discussion. So let me first say, Steve, and you're free to rebut my biography if I got anything wrong. So, but I'm going to ask you a very basic question. What is COVID-19? I mean, we know it's a virus, but what is it about COVID-19 that makes it particularly difficult and lethal, and what makes it spread, and how does it work? And we have kind of a science audience here, so I think they might find that discussion interesting.
Well, let me just start out by saying that it's great to see you again, Howard, at least virtually. I was wondering whether or not you used that background because that was actually you in that spacesuit, and you were really, coming from quite a distance away to this video conference. But I assume that that's not the case. It's also great to see Lisa. So
Well,
in
before you go on, this spacesuit is actually what I wore to the supermarket the first
I
couple of months of COVID-19, but now I've loosened up a little bit.
Well, that makes perfect sense then. So, coronavirus is obviously it's a virus. We know that there are lots and lots of different viruses. Coronaviruses are a class or a family of viruses, and there are a bunch of coronaviruses that cause infections in various species, but don't cause human infections. But there are a small number of coronaviruses that have been around for a long time that are known to be associated with human disease. And in fact, coronaviruses are one of the sort of the more frequent causes of common and typical colds, and have been around and have been known for a long period of time. But what was sort of unusual is that we didn't really recognize that there were some coronaviruses or that these coronaviruses can mutate in ways to be able to cause more severe disease in humans. And the first evidence that we had of something like that happening was in late 2002 when the SARS virus emerged onto the scene and started causing fairly large outbreaks, small in comparison to what we currently see now with COVID-19, but caused an outbreak to begin in Asia. It started in southern China, and it wasn't clear initially what the cause was. In fact, I was at CDC at the time and was watching that situation very closely, and authorities at that time in China reported that it was due to other commonly known causes of pneumonia. And one of the reasons that there was so much concern about SARS initially was that we had only recently recognized that H5N1, the avian influenza strain, could cause serious human disease, and it did that in Hong Kong. And there had been a couple of reports of H5 infections earlier that year in China, and people thought, well, maybe that was, what was going on. But it turned out eventually it was figured out that it was a new version of coronavirus that seemed to have originated in some wet markets in southern China. And in those wet markets managed to infect certain wild animal species like civet cats that were being sold in that market. And it was an unusual situation that a healthcare provider in southern China traveled to Hong Kong one weekend in the midst of this problem going on in southern China to attend a relative's wedding. Turns out he carried the virus with him. He stayed in a particular hotel in Hong Kong, and a number of other individuals that were literally staying on the same floor as him. Of note, he was in room 911, but a number of other individuals on that same floor managed to get exposed to him, even though he stayed in his room. The way that they got exposed is unknown. They were from different parts of the world, including from Canada and including from Vietnam and including from mainland China, Singapore, etc. And they carried the virus with them to all other parts of the world from one single individual. That was the genesis of the larger SARS problems, and it woke people up to the fact that coronaviruses can cause quite serious disease. SARS went away. It had some very unique characteristics that made it much, much, much easier to control than the current problem. And one of the characteristics of that virus is it really didn't cause asymptomatic disease, and it really wasn't very transmissible. Most people that were identified with SARS never transmitted it to anybody. In fact, that was about the case with 90% of individuals. And so simple quarantine and isolation controlled that outbreak to a surprising degree. Coronaviruses then stayed quite quiet until 2012. when a different coronavirus, Middle East respiratory syndrome coronavirus, was identified in individuals that had come from the Arabian Peninsula, from Saudi Arabia specifically. And initially as sick individuals, specimens were sent to Europe. A new coronavirus was found, and then it was found in several individuals who had traveled to Europe to get care from the Arabian Peninsula. This one also causes very severe disease. In fact, in some ways, it causes more severe disease than SARS did, but it's not very infectious. It's not very easy to transmit it from what appears to be its natural host, which is camels, interestingly enough, and that's probably part of the reason why it's associated with the Arabian Peninsula. And so, in contrast to SARS, Middle East respiratory syndrome has stayed around ever since it was first identified in 2012. And so there are cases of it every month. But there are very small numbers of cases. The only major outbreak of Middle East respiratory syndrome outside of the Arabian Peninsula was a traveler from South Korea who went home to South Korea. It wasn't recognized, and he caused a fairly large cluster of infections. But otherwise, it just kind of sort of piddles along with small numbers of cases on a monthly basis in the Arabian Peninsula. And you know, it's just kind of out there, even though it causes a fairly severe disease. And then we have this latest incident, which by all accounts appears to be a new virus, and a new virus that appeared in sometime last fall in Wuhan. By all accounts, it looks like that this is a naturally evolving virus. There have been questions about whether or not it could have been synthesized or bioengineered, but analyses have not suggested that that's the case. It looks like that this is a natural variant that evolved into becoming adapted for transmission in humans. And it looks like, similar to the SARS virus, that its origins are in bats. There have been studies that have been done in China ever since SARS was recognized in 2002 to look for other possible coronaviruses that could be future problems in humans. And so they found viruses that look very similar to this one in specimens collected from bats a number of years ago. There's also been some discussion about whether there may be some intermediate host associated with this one as well. And the one that has sort of been the lead candidate is pangolins. I don't know very much about pangolins, but they've come up in relation to COVID-19. But this one is quite different in several really critical ways from those other two viruses that are associated with severe disease. And that is because it has a much wider spectrum of illness, where a sizable number of people that get this infection never develop symptoms. They're asymptomatic. That looks like it can occur in about a third of all infected individuals. And in contrast to these other two coronaviruses, which cause really severe disease and cause most people to end up in the hospital, you know, if you're asymptomatic, or if you have a very, very mild infection, which a large proportion of the rest of them do, there's no reason you can't get on an airplane. There's no reason you can't get on a train. There's no reason you can't visit relatives. There's lots of things that you can go to work. You can do all kinds of things. And it was hard to do with the other two severe coronaviruses because of the severity of their illness. And so this one has managed to find sort of the sweet spot that a pandemic virus really needs to be able to do, to become pandemic, which is that it has the ability to travel, and it has the ability to travel pretty easily in people who aren't either very sick or in people who don't have any symptoms at all. And that's been its sort of secret sauce, is its ability to be able to travel and to move in ways that you don't know that it's doing. And so one of the things that we've seen repeatedly when we've been able to really assess that is that it ends up being someplace before you even know it's there. So it was clearly there in northern Italy. before anybody recognized that it was there. It was very clearly in the United States before anybody really recognized that it was there. We know retrospectively that it was here earlier than anybody knew that it was here. And it was spreading very, very, very silently, either through asymptomatic individuals, or it was spreading in people who had very mild disease that nobody really questioned what that disease was. And then all of a sudden it gets to a critical mass where you start seeing real problems with this virus. And that's been its key to success and why it's been able to do what it's been able to do. Everybody predicted that something like this would come along, and now here it is.
Okay, I think in a little bit we'll talk about some of the decisions that businesses and governments have to make about when to open and when not to open and how to react. But I wanted to first talk a little bit about the vocabulary. So we see in the news people talking about community spread and then herd immunity. Mm-hmm. And if you could talk a little bit about that, kind of the life cycle of an epidemic or pandemic in those terms.
So, I mean, one of the things about a pandemic strain, and you have to appreciate the fact that all pandemics that we've had recent experience with, certainly in any of our lifetimes, and even over the last greater than, past century, have all been influenza viruses. So we all know the 1918 pandemic. The only other couple of pandemics have been other influenza strains. And so our experience and the way that we characterize, the potential for pandemic agents, is that they have to be something new and different. And in particular, they need to be something new and different that hasn't previously circulated in human populations, which means that nobody anywhere in the world has previously seen this virus and has immunity that's specific against this agent. And certainly COVID-19 fulfills that. And so if you were, and a lot of the studies that have been done, looking at diagnostic tests or looking at, antibody prevalence and things like that, what they do is they take specimens that have been banked, human specimens that have been banked prior to what we believe is the earliest, recognition of this virus. And you look to see, 2 years ago, if you had, a banked specimens, can you find any evidence that there's any existing antibodies against this specific virus? And in fact, you use those as control specimens a lot of times. And all of those studies that have been done to date can't find any evidence that this virus was causing disease in human populations or causing infections in human populations before last fall. So this was a new virus in humans, no pre-existent immunity. And so anybody that would see this virus was eligible to become infected because there was no background immunity in the population. And that's a critical feature of a pandemic strain. The other is that it causes, severe unusual disease. And this one also certainly, checks that box. And that it's readily transmissible from human to human. So it met all the three criteria that we generally use to determine that something is a potential pandemic strain. And so this one checked all of those boxes. And so what we see with COVID-19, and we can talk about the different ways that this virus is potentially transmitted, but suffice it to say the major way that this virus gets transmitted is when somebody who has this virus present in their respiratory tract, either in their upper respiratory tract or their lower respiratory tract, comes in contact with somebody, expels that virus, exhales that virus in general, and somebody else breathes it in. And that's how this occurs. And we know from virtually every epidemiologic study that that's much more likely to happen when you're in close proximity to that individual. And that's where the infamous, 2 meters or 6 feet comes from, because all of the studies have shown that the likelihood that you're going to get infected with this if you are in the vicinity of somebody that's carrying this virus, whether symptomatic or asymptomatic, is much greater if you're in close proximity to them, and you're in close proximity to them for more than a split second. You know, it's not like you're walking by these people. It's you're sort of around them for some period of time. The CDC generally uses 15 minutes of being in close contact as really being at risk of having transmission of this virus. There clearly are some circumstances where it can be spread more widely. We've seen this repeatedly in indoor settings with poor ventilation. And you know, there is this question about the degree to which it can be transmitted to others through surfaces. We know the virus can hang out on surfaces and can survive on surfaces for some period of time. And so if you're in the unfortunate circumstance where there's live virus sitting on a surface, you put your hand down on that surface, then, you know, rub your nose or put your finger in your mouth or rub your eyes or do something like that, you can transmit it. But that's thought to be, in general, a relatively minor route of transmission. So those are the main ways the virus gets spread. And what you see is that, you know, because there's people who don't develop symptoms and there's people that have very mild symptoms, and this virus appears to be pretty easy to transmit when you're in close contact, that you see a lot of spread of this within communities. It's been estimated, and these were some of the earlier sort of estimates, that for every individual infected with SARS-CoV-2, which is the name of the virus, because it looks somewhat similar to the SARS virus, that for every individual that becomes infected, that they spread this virus to 2 or 3 other people. That's where you hear about this R0 of 2 to 3. That's what it means. However, that's an average. As with SARS, there are lots of individuals who don't transmit this to anybody for reasons that are not entirely clear to us. But you know, some of these individuals don't hang out with a lot of other people. The other end of the spectrum is that there are some individuals who are what we call super spreaders. They spread it to lots of people, and for the life of us, we never understood that with SARS. We've never understood it with Middle East respiratory syndrome, and we don't fully understand it with COVID-19. What we do know with the first two is that it was much more likely to occur in hospital settings than in the community, because they were doing lots of things to take care of these people that created aerosols that allowed large numbers of people to become infected. But in this situation, most of the super spreader events appear to be happening in community settings from individuals that it's not always intuitively clear why they happen to be super spreaders. And that's what we've seen with SARS-CoV-2 or with COVID-19. But what happens is, as the virus circulates within a community, gets spread from person to person, just like with any other virus or any other infection, when you get exposed to it, whether you are asymptomatic or whether you are symptomatic, the large majority of people, likely more than 90% of people, generate an immune response, which helps to get rid of it. And once you generate that immune response, your body has immunologic memory that allows it to not get reinfected very easily with this virus. And as that occurs, and as the virus circulates in a community, the proportion of individuals that fall into that category grows over time. So we see these serosurveys that you hear so much about, where they draw blood from a representative sample of the population. They try to figure out how many of them have evidence that they've been infected through the presence of antibodies, and they estimate what proportion of the population has actually been infected. And in New York City, it looked like after their wave of infections, it was somewhere in the order of 20 to 25%. In most other parts of the country, it's been much lower than that. In places in Europe that were really hard hit, it was for the most part somewhere around 5 to 10%. So it looks like there's huge numbers of people. When you talk in terms of the total population, it's actually not that great. We know for other pathogens that are easily spread from person to person, what level of immunity you need in the population, which is this concept of herd immunity. What level do you need to really be able to block the virus from continuing to spread? If all the virus is doing is coming in contact with people who are already immune, then it's not going to be able to continue to spread within a community because it has to keep on finding new people to infect. And it's been estimated that with this virus, just based on its transmissibility, that the proportion of individuals that are immune probably needs to get up somewhere in the range of about 60%, although there is some debate around whether it needs to be that high. But suffice it to say, even when 20% of the population has immunity, that's 1 in 5 individuals that then can't get infected if they come in contact with somebody with the virus. Another critical issue about this coronavirus, as well as other coronaviruses, and it has implications for vaccine development, is we don't know how long that immunity lasts and whether or not it wanes over time. And individuals who right now, if they were infected a couple of months ago, are really immune from getting reinfected, will they still be in that circumstance a year from now, 2 years from now? And we don't quite know the answer to that. Although we do know with other coronaviruses, especially the ones that cause colds, that immunity doesn't last very long. And so our assumption is that that's probably going to be the case with this one as well. And that herd immunity, if the virus doesn't continue to circulate very widely in a location like New York or Washington, eventually that herd immunity will start to dissipate.
Does a virus like this mutate, and would that affect the duration of immunity? Or the effect
all viruses mutate. I don't know of a single virus that doesn't mutate. However, their rate of mutation varies markedly depending on the virus. And so we have viruses that really mutate very, very quickly. Probably the best example of that is flu viruses, where that's why we have to create a new vaccine every year, because there's always new variants of flu viruses that are popping up because of the way that flu viruses are able to mutate. HIV is another example of a virus that, as it reproduces, reproduces relatively sloppily, makes mistakes, and those mistakes accrue in various HIV viruses over time. And so you see various trees of HIV viruses over time. Coronaviruses also mutate. They're RNA viruses. RNA viruses are particularly susceptible to mutating. This one, though, is a little bit unusual in that it does have in its genetic material, and it has a pretty large genome in comparison to many other viruses. In its genetic material, it has a mechanism that can correct some of those mutations. A lot of those mutations will also be what we refer to as dead-end mutations. They will occur in a critical part of the genome that the virus really, 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 really needs to reproduce. And if that's the case, it's a dead end. The virus can't reproduce anymore. But like with all other viruses, mutations do accumulate in coronaviruses. And there are lots of studies going on around the world, and lots of collaboratives collecting and collecting and collecting SARS-CoV-2 strains and looking at changes. Now, we have seen a couple of significant changes, and most of them have not been thought to really affect the type of illness or the severity of illness that occurs with COVID-19. There has been one mutation, the D614 mutation, that's been seen. That's the position on the genetic material in the spike protein gene that is believed to have given the virus an ability to maybe spread a little bit more easily from one person to another, even though the severity of disease doesn't look any different. But the rate of mutation of SARS-CoV-2 is not really spectacular in comparison to many other viruses that we've seen. And that's despite the fact that it's now, through 25 million confirmed cases. And we believe that's a marked underestimate in terms of the number of humans that have been infected. Despite that, there really hasn't been very significant change in the virus that's circulating around today from the one that was circulating around back in January when it was recognized. And the one thing that we do know is that all of these mutations have not very significantly affected the critical part of the virus, which is what's known as the receptor binding domain on the surface of the spike protein. That's the area of the spike protein that the virus uses to latch onto cells. That really hasn't changed very much in a way that affects the ability of the virus to infect people. And that's a good news story because it means that all of these vaccine candidates that are being worked on that predominantly act against the spike protein and predominantly act against the receptor binding domain are just as effective now as they would have been, when they were first being developed 6 months or so ago. And so it's believed that it's unlikely that this virus is going to mutate sufficiently that, any of these, vaccine candidates and other monoclonal antibodies wouldn't continue to be effective for some period of time. Although at some point there will be mutations in that receptor binding domain, and then we're going to have to deal with them. I just don't know how long it'll take, probably a couple of years.
So we've heard some talk about how viruses such as this can, not the virus itself, but the effect of the virus can get worse as the weather gets cooler, as we get into the fall season. And we know obviously that happens with influenza. And do we think that is going to occur with COVID-19 as we get into the winter months, or is COVID-19 different?
Well, it's not really known yet. Obviously, it seems like anybody that's listening to this, it seems like COVID-19 has been around forever. But in point of fact, it's been, 8.5 months now that we've really known about this. And so there are a lot of unknowns, including what it will look like in terms of seasonality. I, from the very beginning, have characterized this as being a wave virus, a virus that comes and goes in waves. The other coronaviruses, the ones that cause colds, are all seasonal viruses. That's just their characteristic, and they cause colds more typically at times of the years where you get other respiratory infections. SARS wasn't around long enough for us to really know whether it was going to be seasonal. Middle East respiratory syndrome, as I mentioned, really doesn't occur frequently enough to be able to clearly discern seasonal patterns. So we can't sort of use the experience with the other two to know. I continue to sort of be in the camp that thinks that this virus, once it reaches its steady state, so you can think of this virus as to a certain degree being like a kid in a candy store right now, or a bull in a china shop, where it's really new, it's feeling its way, it can do things that over time it's not going to be able to do once it reaches some steady state with herd immunity, once vaccines are available to also boost immunity in the population. So the way that it's the things that it's doing now, the way that it's behaving, the way that it's spreading is probably not over the long term the way that this virus is going to behave. First of all, this is not a virus that's going to go away. It simply is way too happy in causing infections in humans to think that somehow magically this virus is going to disappear. I would sort of take that off the table. But over time, you will discern patterns in the way that this virus behaves that you can't discern when it's in its pandemic phase. And I believe that give it a couple of years, let it reach its equilibrium or its steady state behavior, and we will see that it probably will have specific patterns that favor enhanced transmission during the cooler times of the year. Now, that's a bold prediction on my part, but I'll just have to see whether or not that turns out to be the case.
Let me talk about some of the practical ways policymakers, businesses are dealing with COVID-19 and some of the decisions that they're making. You talked about the risk to somebody of getting COVID-19 being a function of how they're exposed to somebody and how long they're exposed to somebody. So we're going to go through a few different scenarios here and kind of the thought process that goes on. So we'll start with kind of a large one. So tonight is the beginning of the NFL season. Mm-hmm. There's a game being played in Kansas City, the Chiefs, and there will be 20% capacity of fans at the game. So there'll be something like between, I think I heard this morning, 15,000 fans in a stadium that had normally been set up for 5 times that, or whatever those numbers are, 10,000, you know, something like that. And I heard a little bit this morning about, you know, considerations. They'll have people spread out across the stadium, but then there are also issues about coming in and bathrooms and things like that. So when you're analyzing something like that, we have an outdoor, Kansas City plays outside. What are the factors that go into making that kind of risk assessment?
Well, that's a great question. And I'll preface it by saying, you mentioned at the very beginning that I'm a baseball fan.
Really, if I remember.
Right? Yeah, when I was during my years at CDC, at one time or another, based on my role dealing with outbreak situations and being, very heavily involved in epidemiologic issues, at one time or another, I interacted with all of the professional sports leagues over various infectious disease issues. Most of it was usually with baseball for no particular reason. But I had longstanding relationships with some of the major league teams. They sort of found me when all of this started for obvious reasons. And so I have been helping some of the teams, and I've also been helping some of the agents of the players. And I can tell you, I've talked to individually a lot of, or not a lot, but a number of players that had specific issues about whether or not they should play, either for personal health reasons or because of family situations. But we went through a lot of these same types of questions in dealing with baseball. I didn't deal with the league. I wasn't involved in the actual protocols that they developed, although I did review them. And some of the same types of questions came up with baseball. And I had said at that time to the teams that I was working with, is I didn't see a reason why they could not have small numbers of fans in the stands. One of them is that they play outdoors. The stadiums are awfully big. They are playing in summertime when it's very warm. A lot of them, the games are during the day when you have UV light, which the virus also doesn't like. But if you could adequately socially distance or physically distance fans in the stands, and you could make sure that they use other protective measures, like have masks on, that there wasn't a reason that you couldn't have small numbers of fans in the stands if you could appropriately distance them from each other. I think that that's a relatively low risk situation in an outdoor setting. This is not a virus that easily spreads in outdoor settings unless you give it a lot of opportunities to spread, such as, hanging out, people, one on top of each other, usually involving alcohol in group settings, or doing things like that, having a pool party with hundreds of people sitting around the pool, then the virus can overcome anything that the outdoor setting can inhibit. But there's no reason you can't do it if you can also control other group points. Not everybody that's sitting in the stands can go to the restroom at the same time. You have to figure out how to get them through the turnstiles in a way that there's not a long line of them, sort of hanging out there. But I don't see a reason why, you can't have, a well-managed circumstance where you can have some fans in the stand. I thought that was the case for baseball, and I think it's true for football as well, as long as, you can control what these people do. And you can't tell them you have to sit here and you have to sit here and you have to sit here. And then 5 minutes later, they've decided they want to change their seat and go sit next to the other person. That can't happen. That's not a recipe for success. But I do think you can manage relatively small numbers of fans. I can't say that 15,000, in a 60,000 seat stadium is the right number. I probably would have gone smaller than that. But I don't see a reason you can't do it.
And it might be just, again, we're using the sports as an analogy before we talk about some other areas. So Hockey and basketball, which are indoors and have smaller arenas, both leagues decided to go in a bubble with fans, have the players quarantined for weeks before they started, and both leagues have had no COVID-19 positives. I assume the calculation is different when you're dealing with an indoor arena of 17,000 people than an open Citizens Bank Park where the Phillies play, or something like that.
Absolutely. I would be very, very hesitant to, right now, based on what's going on nationally, to have significant numbers of fans in the stands in an indoor arena. And the same is the case for the National Football League and Major League Baseball. There are indoor stadiums. I think that's a whole different ballgame than, when things are outdoors. I will say that the other thing that I think is critical to all of these situations that we were talking about is the fact that these people are getting tested. Mm-hmm. And I'm talking about the fans, I'm talking about the players, and
I think every day
are being tested incredibly frequently. With baseball, it's every other day. And with some players, I'm sure it's every day. If they're in a riskier circumstance, they have, a pregnant wife at home, or they have, young kids at home, they're probably testing more frequently than every other day. With the NFL, it's going to be on a daily basis, which I think is necessary. Baseball is by and large not a contact sport, but football certainly is. And the risk of having an infected individual in the NFL is significantly more problematic than it is with, a sport like baseball. Certainly more problematic for hockey and more problematic for basketball. But the reason that they got away with this is creating the bubble. They created the bubble by making sure anybody that got in that bubble didn't have the virus.
Right. All right, so let's talk about some more common types of workplaces. And you consult with companies. I work in a law firm that is trying to figure out, how to transition. And so for different types of settings, say office settings, manufacturing facilities, what other types of considerations and types of accommodations and precautions that businesses are making?
So I did have the good fortune earlier this year to co-write a opinion piece that showed up in the Wall Street Journal with Scott Gottlieb. And that opinion piece was very specifically geared towards what are the considerations that you need to think about if you're trying to get people into workplace settings. And there are, a series of things that have to be considered. Now, some of them, have different impacts and have different issues depending on the setting. When you think about it, there are essentially three types of settings. One is an office setting. One is a commercial business where you have customers that are coming into a setting. And the other is a manufacturing setting. Now, there are some nuances to all of them, but they're the three fundamental settings. But there are certain common features that you have to consider in all of those settings. One of them is when do you have people return? The second is who returns, because, while in general we think that, among adults, virtually anybody is at risk of being infected with COVID-19, not everybody is at equal risk of developing severe disease. And so you have people in the workplace that may be in a group that's at higher risk of developing severe disease because of their age, because of underlying health conditions. There have been questions about pregnancy. So there are certain individuals who probably, are not the ones that you would want to be the first ones in line to come back if you reopen a workplace. So it's who comes back. Second is how do they get back? And, depending on different parts of the country, the use of public transportation varies markedly. If you're working in Manhattan, you're much more likely to need public transportation. If you're working in, Sioux Falls, South Dakota, you're probably driving to the office. And And you know, there's been all of these issues around the risks associated with public transportation. If the public transportation isn't crowded, it's not so much of an issue. If it is an issue. So how do you get there? What sorts of personal protective measures are being used in the office? What about masking in particular? And in what circumstances do people wear masks? And do they have to wear them all the time? Another issue to consider is personal hygiene, you know, hand washing, disinfection in the facility, what sorts of things are being done. And very importantly, what's being done with the air handling system and how is the air handling system being handled? And we know, especially for indoor environments, that air handling, airflow, ventilation, and you know, use of ways to filters that are used in the air handling system are really critical to avoid the spread of the virus in indoor settings. And then there's the issue: can you successfully physically distance people in workplace settings? Can you keep them 6 feet apart? There are many offices that have open floor plans or that use cubicles versus others that you have private offices. A private office situation is much better than an open work plan. The risks are significantly lower. I can say that I was working with a very large company that has a very large workforce. You can think of them as having a campus that's somewhat similar to FDA's campus, but everybody that works there works in a private office. Now that's the ideal situation that you would like to see. And the other things that the workplace has to consider is what's the travel policy? And then in addition to that, every workplace setting that's going to bring people back into the workplace needs a plan for what happens in the inevitable circumstance where there's somebody that shows up in the office that's coughing and sneezing, or that shows up and says that they're not feeling well, or somebody gets tested and turns out to be one of those asymptomatic individuals that was infected and was in the workplace. And so you have to have something that deals with that fire drill. And everybody has to have a plan in place to deal with the fire drill. That's why contact tracing is so important. And in addition to that, you have to have ready access to testing for that individual and potentially their close contacts so that you can identify whether or not that individual who felt unwell in the office or who tells you they've been in the office for the last couple of days and now aren't well and are at home, they can get tested very quickly so that you can make decisions about what has to be done.
And I'll say from my end of the advice my firm gives is obviously those companies have to pay attention to the science and also the privacy law aspects of the privacy of the identity of folks who are infected, and there's bounds all sorts of rules about that, which I don't know, but others do. Some other scenarios I think that come up, and I apologize first for not taking more questions since our chat function isn't working, but I'll anticipate them, Steve. So we'll look to the future in a minute or two, but other scenarios I know, particularly early on in this, where if you're masked, can you ride in an elevator where there's one other person? Or can you pass someone in the street? These kind of quick interactions, assuming your elevator ride is 20 seconds. And we know enough now, I think, to know what the risk is for something like that, right?
Yeah, so that's, as we talked about a little bit earlier, one of them is you have to be in close proximity to somebody who's infected and somebody who is infectious, because the two aren't necessarily the same. And you have to be around them for a long enough period of time so that there's a reasonable likelihood that you've actually inhaled enough of their virus to pick up the infection. We don't quite know what the infectious dose is of COVID-19, but it's probably more than seeing one virus. You probably have to inhale enough of them so that the opportunity for the one of them to sort of impinge on the right cell and cause an infection of that cell and set off an infection actually occurs. And so, not that many people spend 15 minutes on an elevator. Now, sometimes it gets stuck and you end up on the elevator for a long enough period of time.
You have other problems then too.
Yeah, but that's not generally the case. Even in high-rise buildings in New York, those elevators are pretty fast, and it's rare for somebody to be in an elevator for more than 30 to 60 seconds. It may stop at a couple of floors as people get in and out, but it's unlikely that there's going to be a lot of transmission of the virus in an elevator. Having said that, it is a good reminder of the importance of physical distancing, and so you ought to avoid having too many people in the elevator at one time, because even subliminally, it sort of convinces people that they can be closer to each other than we would normally like them to be. So a lot of the settings that I've been working with will limit the number of people who can be in an elevator at one time to 2. But what you don't want to have, is that causes a big lineup of people standing around by the elevators waiting to get into one. That may be, that the cure may be worse than, having more people in the elevator if that's the case. So you have to sort of think about the big picture around what you're trying to accomplish when you make decisions about how many people should be in an elevator. As far as walking by somebody on the street, that too is in general considered to be a very low risk situation for transmitting this virus. Now, that doesn't mean that I don't suggest that people wear a mask when they're out and about. I do. But in point of fact, in comparison to many other circumstances, where you're, at a crowded bar, or, you're sitting, in a house of worship for an hour or two, at a service, walking by somebody on the street isn't very high risk. I get a lot of questions about, can people go to restaurants? Should people go to department stores and do shopping? And my response to that is that, or if you ask me what I've done personally, yes, I've gone to restaurants, but all of the restaurants that I've gone to have had outdoor seating, and I've made sure that I sat outdoors. And if I can't sit outdoors, then I don't sit indoors, even though there are probably, a number of restaurants that can physically distance people to the degree that the risk is relatively low. But that has to be coupled with them having really, really good practices for ventilation, because I think that what we've seen in a lot of circumstances where there's been a lot of transmission, whether it's in homeless shelters, whether it's in prisons, whether it's in crowded, nightclubs, whether it's in houses of worship, has been a lot of people without a lot of good ventilation. To me, that is the recipe for transmission of this virus. And if that can't be done, then I wouldn't go into that setting.
Okay, so looking ahead, and obviously there are a lot of unknowns and at this point unknowables. We have therapies in development, we have vaccines in development. I'll just sort of throw it open to you for observations about, what you think we could be seeing, and not really predictions, because there's not enough really to predict, but just some considerations and some observations you have about where we are and where we're going.
Well, what I can say is that if you were to have asked me back in February if I thought that COVID-19 would play out in the way that COVID-19 has played out in the United States, I would have said it's virtually inconceivable to me that as we sit and have this discussion in September, that there would be 6 million or so confirmed cases, that we would be seeing areas of the country that have tremendous amounts of transmission of this virus, that those places would have reopened in the way that they reopened in some parts of the country, which made it inevitable that you would see rebounds in infections. If you were to have asked me whether or not I thought that was a likely scenario, I would have said I don't see how a country with as good a public health system as the United States has, that would have happened. But it did happen, and so I may not necessarily be the best person to I had to get into Yogi Berra saying, prediction is always difficult, especially about the future. What I can say is that COVID will continue to be around, and that I'm in agreement with most of the experts that the game changer here is a really effective vaccine that can be made widely available and is very safe to use in large numbers of individuals. That to me is the key to building herd immunity. You don't want to build herd immunity in the way that some have suggested in the past and more recently, which is to let the virus spread through the community. Number one, it is a bad way to get herd immunity. And even individuals that have mild disease, I think we're learning more and more that this isn't a one and done circumstance. We hear more and more about long haulers that for a variety of reasons aren't returning to their, pre-infection level of health and well-being. And some of these consequences, are not just sort of, mental dullness or, lack of energy. In addition to those very problematic things, I'm not understating the consequences of that, but you're seeing cardiac difficulties and lots of other organ system dysfunction associated with what looks to be a fairly simple infection. And so, I take heart from what I've seen from many of the countries in Asia, which, have been very successful in controlling outbreaks of COVID-19. Places like Hong Kong and places like Taiwan and places like South Korea, even Thailand, that have had relatively small numbers of cases for their populations, Vietnam being another example, and meter up and down interventions and control measures almost like a thermostat. And so when they see the numbers start to go up, they dial up the heat and they put in place measures to control transmission of the virus. And then a couple of weeks later, you see it quiet down. And they've done this repeatedly now over a period of 9 months and ended up with very few infections in the population. And they will continue to do this. And I would venture that they will continue to do this successfully until a vaccine is available, because that's how you want to build herd immunity.
Right.
You want to build herd immunity without making a lot of people sick. And so I really applaud some of the things that I've been seeing in places in Asia. I also applaud what the Europeans did in very aggressively bringing their waves of infection under control, though it looks like they're getting into trouble again, because that's the way that you keep people from getting this infection until you have another way to protect them.
Okay. Oh, sorry. And by the way, this is not COVID. But
we're appropriately physically distanced.
We are distanced, and I'm on the moon, so I don't know how it's going to survive there. But before we close out, I want to say, the public health system has had lots of challenges in the past, and obviously many different contexts. And I remember all the stories. I'm not old enough for myself to have witnessed it, but my mother telling me about the terror of polio. In the summer until we had a vaccine, and now polio for people in the United States is obviously not what it was. But this could be something, as you say, that will be with us for quite some time. So our time is up. Lisa, do you want me to turn it back to you? And I wanted to thank Steve for all those insightful comments.
Well, before we finish up, I just really want to put in a plug for FDA. This is such a great agency. It's been really, really challenged with COVID-19, not only in dealing with all of the issues that FDA has to deal with, but also the way the agency has been portrayed, in the media and by the public over the last few months and by leadership outside of the agency. I just want to finish by saying, hats off to all the wonderful people who work there, who have gutted it through, a very difficult time.
Yeah, and I will second that. The agency and not just FDA, CDC as well, and others are a real national treasure. And sometimes people don't realize that as much as they should. So turn it over to you, Lisa.
Terrific. Thanks, Howard. Thanks, Steve. We really appreciate your taking the time to do this. Apologies to the group for the little technical glitch on the chat function. We will obviously address that in future meetings. Again, so grateful that you all took the time to join us, and be on the lookout for another one soon. Thanks so much. Take care.
Thank you.
Great to be with you.